Good afternoon, everyone. Welcome to the New York, New Jersey Pain Symposium Fellows and Residents Workshop webinar, The Impact of the COVID-19 Crisis on Training and Jobs. Just a few housekeeping items for everyone to begin this webinar. We sincerely do want this webinar to be interactive and we look for your questions. To ask a question, please raise your hand and we will unmute your line. The moderator, Dr. Dewan, will introduce you and ask you your question. You can also post a question into the chat box. Please keep your questions succinct, and if you would like a specific panelist to address your question, please state that at the beginning. I would like to introduce Dr. Sudhir Dewan, the president of Advanced Spine on Park Avenue, the executive director of the New York Society of Interventional Pain Physicians, chairman of the New York, New Jersey Pain Symposium, and former fellowship director for Weill Cornell University. Dr. Dewan, take it away.
Thank you, Michelle, for your kind introduction. And welcome all the listeners, all the fellows and residents. This is the webinar hosted by the New York and New Jersey Pain Symposium, and specifically is focused for the residents and fellows. We have excellent two panels, and the first panel will focus on the impact of the COVID virus on the hiring and the job contracts. And then there is another panel to follow, which will focus on the role of program directors and the mentors during this crisis. So without delay, I would like to go on the first panel. The first speaker on this panel is the expert, Adam Guttel. He's a principal in the Long Island, New York office of Jackson Lewis. His practice focuses on representing employers in workplace regarding the law matters. That includes the preventive advice and counseling. Adam, please take over.
So thank you, Dr. Dewan, and thank you to NYSIP for inviting me to present today. Happy to be here. I can speak a little bit about how employers are looking at this crisis, in particular in the healthcare field, and some of really the three main areas that employers are focused on at the moment. What we're going to talk about first is, let me just see, we could move the next slide. There's the obvious layoffs and furloughs. That's something that employers have been focused on for the last couple of weeks. Question is, does someone get terminated or are they put in some sort of temporary status? A layoff is a termination. That's when the job is, you were told by your employer that the job ends. That's it. With respect to a furlough, that's a temporary situation. And we're seeing a lot of healthcare employers do that, whether it's at staff level or employed physician level. And that means that you're getting notice from your employer that you're not to work, but we have every intention to bring you back. We have an intention to bring you back within a very specific period of time. The other thing we're seeing is either a reduction in pay or a reduction in hours. If there are contracts in place, that takes place. What you have to do there is actually negotiate a new contract. It can be a short term, it can be an amendment, and that's the way that every party can have some comfort that you're going to move forward on an equal basis. What we're seeing, for example, in some office settings is that there's very limited ability to see patients one-on-one. So there's a lot of telemedicine going on. That obviously is not as lucrative and doesn't generate as much revenue as procedures and in-office visits. So the revenue being brought in by the practice is greatly limited. And what has to happen is there will be an arrangement with the physician, to the employee physician, to reduce compensation for a period of time. Usually that's reflected in an amendment to the contract. If it's a furlough, that means you're not working. That means you're to stay home and not perform any services for the practice during that period of time. That's really the nuts and bolts of what employers are looking at the moment. In terms of the next slide, what employers are wrestling with at the moment are, for those folks who remain employed, what are the obligations that the state and federal government have put on employers in the workplace right now? And there's really a couple things that are going on. One, New York State, when things really got ramped up, issued a law having to do with a quarantine. If an employee notifies their employer that they are under an order of quarantine by the state because of exposure or infection to COVID-19, New York State requires employers to provide 2 full weeks of paid sick leave. There's a cost associated with that to the employer, obviously. Then the federal government came in and expanded on that law. There are now 6 categories under which an employer has to provide paid sick leave to an employee, and this is for active employees. If you're furloughed, if you're laid off, obviously this would not apply. But for those who remain on staff, the employer has to provide up to 80 hours or 2 weeks of paid sick leave for a variety of circumstances. And the most likely one that we're seeing right now is an employee calls the employer and says, I've been exposed or I'm experiencing symptoms and I'm trying to seek medical attention, but it's hard to get to see a doctor. I can't get tested. We don't have any level of comfort that it's guaranteed that I have COVID. The federal law requires the employer to provide benefits in that case. There's a benefit to the employer, though. They get tax credits. Any amount of money that is paid to that employee for that period of time under that law for the sick leave, they would get a direct tax credit on against their payroll taxes that they otherwise pay. So the concept is to try to make the employer whole for what they have to expend. The other issue that comes out of the new expansion of the FMLA, or the Family Medical Leave, is to provide additional paid leave, something we've never seen before, to employees who have children at home, who have no other access to childcare, and the school is closed. That law, this new federal law, actually requires employers to provide up to 10 unpaid days off, and then you have to start paying the employee for a period of time up to 12 weeks after that if the school remains closed. And in the current environment in New York, that's something that we're seeing quite a bit. There are 2 exceptions to this law, this new federal law. One is the healthcare exception, and one is whether it impacts viability. If it's a small medical practice under 50 employees, if complying with this law would impact the actual viability of that practice, the employer does not need to comply and does not need to provide those benefits. The other major issue, and we're not seeing a lot of that because of the tax credit issue, the other issue is the healthcare provider exception. They came out with guidance, the Department of Labor did a couple of weeks ago, saying that this law, these requirements do not need to apply to healthcare employers because they're essential employers. Individuals employed in the healthcare field are providing essential service, and it would impact everyone if people have to stay home and the employer has to constantly pay sick leave. There has been some debate about that. In fact, New York State just filed a lawsuit either yesterday or the day before against the federal government, stating that their interpretation of that law is broader than that, and this exception should not apply. So right now, healthcare employers are in a bind as to whether or not they should be complying with this law. Finally, the third issue that all employers are wrestling with at the moment, and which is in the news right now, is the CARES Act. Whether or not, there's 2 aspects to it, 2 major aspects. One is the expansion of unemployment benefits, which provides those individuals who are laid off related to the COVID crisis an additional $600 a week in unemployment benefits. In New York State, for example, the typical benefit is no greater than $505. And it also expands unemployment for an additional 13 weeks. The original unemployment benefit is only for 26 weeks. The other big part is the small business loan, the PPP loan, as it's called. Employers are trying very much right now with every banker they can get their hands on to try to get the funds from the federal government to fund their payroll. And the loan is forgivable. It's a really good benefit for employers. And so what we're seeing is employers are trying, if they furloughed or laid people off, they're trying to bring them back right now. There is a hook, though, with respect to employed physicians. The maximum benefit you can get in this loan only goes up to salaries of $100,000. So they're not excluded altogether, but the employer is not able to fund through this loan salaries that, the amount over $100,000. So,
Adam, sorry to interrupt you. You are expert, so you will have 1,000 questions. So let me just ask you one question regarding furloughs. Is this furloughs one size all, or is it different for different institution? I mean, private practice versus teaching institutions?
It can totally be customized. It's very different depending upon the circumstance. We've seen furloughs where practices are saying we're very hopeful that work will come back. We're going to furlough you for 30 days, and then we'll see you back here in 30 days. We may extend it. We may reduce it. I had a client that called me this morning that said, we did an initial furlough. We need to now extend it. We're going to send out a new letter. Furloughs, by definition, cannot go longer than 6 months. And then the other issue with a furlough is those folks remain employees under certain definitions as opposed to a layoff. So one of the benefits of a furlough is sometimes employers are choosing to furlough, and if the definition of employee under their summary plan documents with their healthcare benefits, for example, still apply to furloughed employees, they can continue to pay healthcare benefits. And you don't have to put those folks on COBRA, which would then require those employees to pay their own healthcare benefits. That's one of the benefits that employers are doing. They're saying, we can't afford to pay people their salary, but we can afford to pay the healthcare benefits, so we're going to furlough. And then they can go collect unemployment.
Is it one-sided decision or is it bilateral?
It's one-sided. It's totally the employer's decision. Whether or not an employee wants to decide and try to get unemployment because they think it's dangerous in the workplace to be there, or they're uncomfortable, or they feel they'll do better with unemployment, that's a judgment call. That's up to the employee. It's really whether or not someone's going to get unemployment benefits is between the employee and the state of New York or the state of New Jersey, wherever they may be. The employer really has no role in that unless the employee leaves. It's a pure voluntary separation. You know, they're leaving because they just don't like working there. There is an expansion now about if you're leaving having something to do with COVID. It's sort of a catch-all, but it's still up to New York State to decide. Or New Jersey.
All right, thank you so much. This short presentation was very informative. Please stay, backup. We will reach out to you when the question comes.
Certainly.
So
Thank you.
next speaker is Dr. Miles Day. He was having some technical issues, but hopefully it is resolved. Dr. Day is the medical director of the Pain Center at the Grace Clinic Pain Medicine Fellowship Program at Texas Tech. He is a tenured 12-week Rex endowed professor of pain research in Department of Anesthesiology at the Texas Tech University, Lubbock. Dr. Day.
Can y'all hear or see me?
Yes.
Okay.
Thank you. Finally, it's working.
Sorry, yeah, there was a little bit of connectivity difficulties, and I'm using my phone. Fortunately, over the years, I've been able to train quite a few fellows, and usually near December or January, I always ask them whether or not they have started looking for jobs or have secured jobs. And some of them would say, what? I was like, yes, he's doing about 6 months prior. A couple of things I would always ask fellows is, what type of practice are you looking for? Some of them, or fewer of them, want to stay in academia. The majority of them will look into private practice. And of course, I would say, okay, private practice, what are you looking for in a private practice? Do you want to join a group, which could be a single discipline group, such as interventional pain management, or it could be a multidisciplinary group, including neurosurgeons, orthopedic surgeons that you would interact with. There are some hospital-based practices where you're an employee of the hospital. And of course, there's others that a colleague of mine will discuss a little bit later. I don't want to steal all the thunder. The thing about academia, the question is always, why do you want to be in academics? A lot of folks say, well, I want to teach, I want to publish. And it's like, well, that is important. At the same time, you need to ask yourself, can you be an effective teacher? One day you're a pain management fellow, the next day you are a pain management attending, and you're training other folks. Sometimes they can be younger than you, sometimes older than you, which has happened in my career. And you fall into that teaching role, and one of the downsides could be that all these procedures that you've learned the last year, you're now teaching others to do, and you don't get as much experience because it's less hands-on. So a few things to consider. If we can go on to the next slide. Two things I tell my fellows is that don't look, when you're looking for a job, one thing you need to think about is, what can you contribute to the practice that you want to join? One of my fellows is looking in Boise, Idaho, and had interviewed with a few groups, and one of the groups asked him specifically, did he do cervical procedures? Because in that community, there was only one group that did cervical procedures. And so that is something that I train my fellows to do, and something that he can take to that area that others aren't doing. So part of it is finding your niche. One of the niches that we learned here at Tech is how to do face procedures with sphenopalatines, trigeminals that a lot of physicians don't do. And so that's something that you can offer your future employer or offer the community that others aren't doing. So when you're looking for a job, think of what you have in your armamentarium that you were taught during your fellowship that you could bring to them, because this is a good way of expanding the scope of the group that you are joining or want to join. And one of the other things is, do you have colleagues in the areas that you want to practice? Because if you go into an area and say you want to be a seller practitioner, you don't know anybody, you're going to have to do a lot of door-to-door, essentially sales, being a salesperson to tell them about you and what your practice is about. But if you go into a community or an area where you have colleagues who can be your referral source, it's a good way to get your practice going, because you will have your colleagues that you've trained with or went to fellowship or residency with that can refer you patients, and it's a good way. So don't always look at, the practice has something to offer me, but also think about what you have to offer, because what you have to offer can be a big selling point and could help you secure that job, especially during this COVID issues. So those are the things that I'd like to stress, and I'll pass it back to Dr. Dewan.
Miles, thank you so much. I do have some questions for you. You have dedicated your life training some world-class fellows and trained almost 100 plus fellows. Just tell us, how has it affected, this COVID crisis affected or impacted your training to your fellows? And what has really, in response, you have heard from your fellows from shortcut training?
What we have done is we have had to alter how we do our day-to-day activities. We've spent a little bit more time with scholarly activity, which is helpful. Journal clubbing, still doing with telemedicine. Fortunately, we do a lot of procedures, so the majority of the procedures, thankfully, the fellows have had a lot of experience doing. I tried to encourage them to do more reading, especially studying for the different topic specialties that they have to rotate with and will be on their upcoming exams. So we've slowed down a little bit, but we've been able to utilize new ways of seeing patients through telemedicine, which is something in Texas we were not allowed to do prior to the COVID crisis. Pain management was excluded. And so that has been integrated. But we tried to maintain as normal life as possible. One of my fellows already has a job. The other is a little bit worried. But you get creative. And so far, aside from having a slower clinic, we've been able to manage.
So that's very good. I was coming to that point that your program is very reputed. Usually they don't have a problem finding the job. But now, as I said, another fellow is worried. Has your goal changed in terms of how you're going to help your fellows to find the job and to help them stabilize?
I think there's a lot of phone calling, speaking to the prospective employers. Sometimes they probably most recently, I've had more contact with the employers than I've had in the past. We've had to make suggestions to be a little bit creative as far as securing a job and salaries. One of the things that the one fellow who doesn't have a job yet, he was willing to take a reduced salary for the first few months, and then that would increase as this COVID crisis subsides, at least for the summer. So we've been able to talk and discuss different ways of securing the job, probably not making the type of money one would like in the beginning, but at least it's securing a job.
Excellent. Thank you so much, Miles. Please stay as standby because we will have more questions for you, and we're going to move to our new speaker. The next speaker is going to be Dr. Christopher Garibo. Dr. Garibo is the former president of NICEP. He is also course director of the New York, New Jersey Pain Symposium. He is a professor at the NYU of the Department of Anesthesiology and Pain Medicine, and he's the director of pain medicine at NYU Hospital for Joint Disease. Dr. Garibo, please take over.
Thank you. Thank you, Sudhir, and thank you to Boston Scientific for putting together this wonderful program. I must say, I think it's safe to say this, that in the history of pain medicine, there's never been an event that has had a greater impact on our practices as attendings, as well as in our fellowships across the specialty spectrum. And therefore, what we're experiencing right now is unprecedented, and it has in many ways devastated the clinical experience that our fellows get. So as Miles said, that what are we offering the practices that we're going into? Is it cervical procedures? Is it implantable experience? Is it chronic opioid therapy? We're offering a complete package in our training. Although we do that, there's been near total elimination of the outpatient experience in the New York City area, close to complete elimination of pain procedures, whether it's office-based or fluoroscopic. There's been efforts to conserve PPE, to decrease disease transmission. Patients have been advised to stay home. Hands-on experience has been virtually obliterated. Even the inpatient experience for our inpatient fellow, which they spend 3 to 4 months a year, has been significantly affected and has declined by about 50%. But there is a silver lining to all of this. This has made us more adaptable. This will change the way we practice pain medicine in the future. And our current fellows are being trained for the future, whereas our past fellows have not been trained through, for example, experiencing clinical practice through telemedicine. So although it has been quite impactful on the clinical experience that you're getting, telemedicine is something that's probably going to be used in the future to screen patients, to see who's appropriate for us, to see if the patient is an appropriate candidate for the practice, to have a Q&A session with a patient in the form of an E&M visit. So there is a silver lining to the current experience due to the COVID-19 epidemic. But nevertheless, I think it's probably a net negative. There's been suspension of one-on-one outpatient teaching. The New York City area has been devastated. Many patients are staying home. There's been reduction of educational activities and didactics. The departments are so distracted right now in academic settings, whether if it's NYU, Cornell, Columbia, Sinai, or wherever it may be in the New York area. We're just consumed by the COVID experience and don't have much time left to teach our fellows or see patients with our fellows. Next slide. Because many of us have been redeployed, the faculty and the fellows, for example, we've had some fellows who were redeployed to Bellevue, to intravenous teams, to turning of the patient teams. We've had a couple of faculty that have joined the airway teams. So we just don't have the staffing that we used to have, and our fellows are being used in other capacities. So what we do have to offer is that as we begin to get back into clinical practice of pain medicine, starting sometime next month, we can modify that experience to suit what has been missing in the fellows prior 6 months before the COVID crisis. Whether if that's implantable experience or chronic opioid therapy experience or lumbar transforaminals that they want to see more of, if there's a trial going on, a pump implantation, a lumbar sympathetic block, or an orofacial or a craniofacial block that needs to be performed, it is something that the fellowship should be flexible with to pretty much put the fellows where they need to go to round out their experience and get the experience that they're lacking because of the COVID crisis. You got to be flexible going forward as well. And I think all of us come from different backgrounds, whether if we have an ED fellow or a psych fellow, neuro or PM&R and anesthesia, each specialty that goes into pain medicine have their strengths and weaknesses. And therefore, we need to be adaptable in the remaining 3-4 months of our fellowship such that we can give the fellows the technical experience and the neuraxial experience in particular so that they come out competent in performing cervical, thoracic, and lumbar procedures. It may not be complete, and I think 1-year pain medicine fellowship, even if it wasn't hit by the COVID-19 crisis, would still be significantly affected in a way that is very tough to come out of a fellowship and be good at everything. whether if it's cervical procedures or craniofacial procedure or implantables. It is something where it's a situation where you need to know your limitations and gain some postgraduate experience through workshops, attending New York, New Jersey Pain Symposium, ASIP meetings, and what ASRA meetings, whatever is required to gain that experience. And I think that probably applies to a greater degree for the current year than in the prior years. So at the end of the fellowship, which is nearing, the Clinical Competency Committee ultimately has the responsibility to assess that readiness. And I think in many situations, our fellows will probably be ready to be practicing pain medicine independently, with the acknowledgement that they do know their limitations, just like as if the fellowship was not hit with the COVID-19 crisis. Next slide. So therefore, there is a silver lining. We are more familiar with telemedicine. Telemedicine is going to be a part of the practice of pain medicine going forward, is the probability. Many practices have developed a wait and see attitude. So therefore, it is a challenging job market. In fact, many faculty, several colleagues that I've spoken to that have been in practice for some time have taken pay cuts of up to, I would say, up to 30% or so on a temporary basis. Incoming salaries are also reduced if they've been offered at all. So many contracts are being canceled. Salaries are not what they used to be. It is a challenging job market going forward for the next 12 months or so. Outpatient volume projections are poor in the Northeast, in the New York City area, simply because of the projected social distancing that is probably going to be implemented. We're not going to get back into how things were. We're not going to just sort of get this over with and go back to how things were. Things are going to be different going forward, at least for the next 6 to 12 months or so, if not for a projected longer period of time. So whatever we're going through that now, part of it is going to stay with us. And I think part of it is really depends on the geography as well. The Northeast has been particularly significantly impacted. Outpatient projections, procedural projections are definitely attenuated in this area. We will get back, but we will not be at full speed for quite some time. For us to go back to our prior productivity of, let's say, doing 20 procedures in half a day, is probably something that's not going to be realized with the social distancing and other expectations that are to be in place. So therefore, the higher in practice of productivity also need to be reduced accordingly. Next slide. So therefore, we do need to be flexible in our practices. We may need to practice our primary specialty, whether if that's emergency department, anesthesiology, neurology, or psychiatry. Attend conferences, attend the various cadaveric workshops and other didactic sessions and panel-based and interventional sessions, such as, for example, that will take place in New York, New Jersey on November 5th through 8th, the ASIP's annual meeting on September 4th through 6th. Get that hands-on experience, get that clinical experience, be diverse, be able to do acute pain, inpatient pain, chronic opioid therapy, and interventional pain management. Of course, interventional pain being the heart of your skill set. Know your clinical limitations, and you're geared for telemedicine like no other. And us as the program directors have your back going forward.
Chris, this is wonderful. Thank you. As always, you do bring a lot of informative information. I have a question. Actually, this question is from Mexico, somebody from who knows us very well. And the question is, what would you do? You know, there are some fellowship programs are 2 years program, and one program is all didactics and research type, and second is all procedures. Now, if they lose the year like this for the procedures, how would you, and what would you do for your fellows to make this up?
What I guess I would question and ask them, what are they lacking, especially within the specific practice that they're going into, and give them targeted training so that they can take off in their practice and get off to a comfortable start in that practice rather than being insecure with their skill set.
Oh, that's good, great. There's another question which talks about the telemedicine training in fellowship program. Now, is this by default, or you are actually training your fellows to get enrolled into telemedicine? And how is it accepted by your fellows?
Currently, our fellows have been doing some telemedicine. It's been very limited. It is impractical to do telemedicine with the fellows, given that we also have to see the patient. There are definitely some technological barriers, but we did have a presentation to them. We had multiple discussions with them as to how to go about doing telemedicine. And I must say, our fellows, given they're much younger than many of us, are very good with technology and implementing Zoom and webcasts and telemedicine. So I expect that they will be very comfortable doing that. But I think that's the new paradigm going forward, Sudhir. I think this almost improves our marketing capacity and our geographical outreach in bringing patients into our practice. It's an opportunity and silver lining to what's happening now.
Excellent. There's always some issue of supervising because this is a teaching program. So if your fellow is doing a telemedicine visit, how do you supervise them?
It's been, I mean, in speaking with the faculty, it's been tough to oversee that telemedicine aspect that the fellow may accomplish. There may be some subsequent phone conversation, but that is something that technologically needs to be sorted out. It's very sort of tough to be on the same call. Technologically, it's not something I've seen yet, unless it's something that's available that I'm not able to take advantage of yet. But for that to happen, it needs to be 3 people on the call, myself, the fellow, and the patient. And I'm not sure if the technology is ready for that yet.
And I think there is always documentation, and you can always review the documentation and point out some of the mistakes.
Yeah.
Thank you so much, Chris. Please stay stand by. We will have more questions, and we're going to move on to our next speaker. Our next speaker is Dr. Sean Lee. Dr. Sean Lee is one of the key opinion leader of our area. He's director at the National Spine Pain Centers, and he practices in New Jersey. He has contributed a lot in neuromodulation. He's a course director at the New York, New Jersey Pain Symposium, and he's a regular speaker nationally, internationally regarding different topics of the pain medicine. So please, Sean, take over this next topic.
Well, thank you, Dr. Dewan. I want to give thanks for inviting me, and you've always been a great mentor and a leader in education. So first off, want to give credit to our sponsors to take the time and give us the opportunity to provide some guidance to the fellows. These are challenging and unprecedented times, as most private practitioners and even academic practitioners are struggling to maintain their practices. I foresee definitely a equally challenging time for the fellows who are trying to figure out how to get through what should be the most exciting times of the year. They should be looking for jobs and so forth. When I was coming out of fellowship, I had mentors like you guys on the panel to help me through this. But unfortunately for all of us here, this is our first pandemic. We've never gone through this before. So there's equally lots of new challenges ahead of us. So anyhow, I wanted to kind of take a different approach to this. As part of a large national private equity-owned pain management group, I wanted to showcase what it was like for us to encounter such a global pandemic from the inside. And I had some discussions with our CEO to get some advice and guidance. What I wanted to show the fellows is that while they're looking for jobs and thinking about issues such as hiring and contracts, what it's like from the employer side. So it's always said that you have to know thy enemy to be able to accomplish what your goals are. So I wanted to give a peek to what the corporate side and what a practice such as ours is going through and thinking of in terms of hiring and firing. So what we did was back in January, where we're all probably at NANS, being able to say hello and hug and shake each other's hands, we knew that there was a virus brewing in China. And knowing this, we anticipated that there may be a clinical a disruption to our clinical practice. So National Spine, my parent company, assembled a COVID-19 task force. That included chief medical officers, included business folks, included health economics folks, included attorneys. Obviously, you can't get anything done without lawyers. And what we wanted to do was we wanted to make sure that we were able to get through this and become ahead of the curve. or ahead of the curve and survive through this. So we wanted to maintain communication not only to our patients, but to our team members. So we looked at it from two perspectives. One, from a clinical practice perspective, we wanted to reduce exposure, obviously, for our patients and for our staff. We wanted to prevent viral spread, so we implemented procedural things in the offices, making sure that patients don't sit next to each other in the waiting room, making sure that there's a strict screening process. And we wanted to preserve patient access to care. So as you know, we have a very vulnerable patient population, and in times of disruption, in times of global pandemics, healthcare disasters, they become even more vulnerable. We wanted to make sure we stayed in touch with them, and that's through telehealth, and that was essentially launched within a week in our practice. From a business perspective, we wanted to preserve cash. We wanted to maintain our cash liquidity. Lots of sacrifices and decisive measures and restructuring was done. I'll speak about it in a second. Implemented cost-saving measures, and obviously the main portion is telemedicine. There have been lots of discussions and additional webinars on that, but I won't dive too deep into telemedicine per se. But that was one of the ways we used to continue to practice medicine and to care for our patients. So what are the measures that we took? Well, obviously we had to look at our staff. And unfortunately, there were sacrifices in this process. Immediately that we knew that especially in New Jersey being one of the hotspots, we just cannot have on the ground marketing staff going to offices and subjecting them to risk of exposure. So our sales team were unfortunately laid off. That was, in good sense, we were able to project cost savings. And in addition, we had another 171 employees that were reduced. That came from top down, from the corporate level all the way down to staffing level. And it was very unfortunate. Myself and our region, we lost 8 members of our staff. But the nice thing about that is we did it in a decisive manner so that they can be at the front of the line getting the appropriate government aid, so that we're not jeopardizing their ability to continue and survive through this. We all took salary adjustments, and this is humbling, from the top person, CEO, down to the front desk staff. Myself took considerable amount of reductions in our salary. That is allowing us to survive. And let me just go back one slide. I just want to make sure I don't miss anything. And other things, we renegotiated contracts. We took cuts on our bonuses. We applied for the necessary government relief plans. Nicely to say, we just received our first of initial CMS funded for Medicare, the relief funds. We also implemented a hiring freeze. So that may come not as a surprise, but also I want to reassure that the fellows who are looking for jobs right now, that doesn't mean that there isn't jobs out there. That means right now we may be hiring, but I would say in about 3 months, 6 months, I think there should be a boom in hiring, because I suspect there may be some practices that may not survive through this. I suspect that there's going to be a need for us to expand. So I don't want to paint such a negative outlook. I think there's a silver lining in this. Next slide. So by anticipating changes, we expected to see about 50 to 80% reduction in volume, but right now we're seeing about 70% preservation of our patients population. So that's a somewhat of a positive in a very dark sort of time period. All of our offices remain open. We provide telemedicine capabilities through all of our offices. We want to maintain contact with the patients, provide urgent, emergent interventions. For example, I still have to fill my intrathecal pumps. That's an obligation that I made to my patients, that I will be there for them.
Sean, we have a lot of questions coming in. So, just for interest of time, please stay standby for the questions, and we will have to move to the next speaker because of the question.
I'm pretty much done.
Okay. All right. So The next speaker is Dr. Dang, and he is going to talk about the private practice. He's in a private practice. He has extensive experience in pain medicine and in the neuromodulation. He practices Garden State Pain Control, the surgery center. Um, he has special interest in cancer pain, failed back surgery syndrome, complex regional pain syndrome, and neuromodulation. We would like to hear his about his practice and impact of the COVID crisis.
All right. Well, thanks,
Dr.
Dr.
Dang.
Dewan, for the introduction. I'll start by reviewing some of the different practice models we see in pain medicine. I graduated fellowship in 2016 and considered most of these practice models when deciding on my first job. Each of these practice models have been affected by COVID-19 pandemic, but they've all been affected in different ways. Something we can learn from this almost complete shutdown is what we can expect going forward in case anything like this ever happens again. In general, speaking in terms of resources available to stay afloat during times of near shutdown, we have to look at things such as available cash balance, cash inflow, and total cash flow. There's obviously no right answer or wrong answer for fellows that are considering any of these different practice models, but there are just considerations and decisions you have to be made aware of and make an appropriate decision with stipulations being present. So I'll start with the first one, which is solo practice model. In this model, and some of you were considering or are considering starting your own practice, it will require a higher amount of capital to run. There are things to consider, including startup costs, cash outflow, which include expenses, costs of rent, staff salaries, equipment, which may include a C-arm. Given the uncertainty that we have in the upcoming months, opening up a new practice today will come with greater risks, as the influx of cash may not be high enough to cover the costs. The next one is the hospital-based practice, many of which are run by anesthesiology or rehab groups. Things to consider include possible complete shutdown of the pain arm of the practice. You may be required to work in the operating room if you're an anesthesiologist, or the floors or units to cover the floors or units over the next few months. So if you wanted to join a hybrid practice model prior to the end of your fellowship, expect to do maybe a little less pain management. In terms of weathering the economic effect of COVID, the risk of like complete collapse in this sort of practice is particularly low. The next one I want to touch base on is the private practice model, which I'm a part of. Our practice is multi-specialty, which includes PM&R pain doctors, anesthesia pain doctors, and orthopedic surgeons. We've seen a large decrease in the volume due to COVID in the last month. We've employed telemedicine and closed our surgery center in the last month. So essentially, since we've stopped doing procedures, we will see the effects of decreased revenue in the next few months. So something to consider, some practices have obviously furloughed their employees to decrease the outflow of cash, to maintain positive cash flow balance. Depending on like cash balance, it's important to realize private practices may have to terminate certain employees, including mid-levels, PAs, NPs, MAs, just to stay afloat. So there may be a hiring freeze in the coming months, but something to note that smaller groups and groups spending a lot of money on things like marketing may have to restructure their plan in the next few months. The next practice model is the independent contractor, 1099. So this is basically the doctor who uses his own LLC to either rent space from another doctor, whether it's a primary care doctor, chiropractor, PT. Essentially, you have a different tax ID from the other physician or healthcare provider, but you share some of the same overhead costs or resources, including staff, equipment. So there's less of a cash flow outflow during this time due to the shared expenses. Next, I'm going to go over locum tenens. There aren't many fixed expenses with locum tenens. A lot of the companies right now are offering to pay for medical malpractice, but be wary of the demand of pain physicians in the next coming months. There's definitely going to be a high demand for anesthesiologists, critical care doctors, people that want to work on the floors, but understand the constraints can include travel. Larger corporations is next, NAPA, National Spine. These corporations may have more resources to fund, to weather the storm. The bigger corporations, the partners in these bigger corporations will likely not be able, they may not take distributions, which will help with their cash balance and ability to stay solvent. Again, depending on the corporation, you may be doing a lot less pain and a lot more of your primary specialty. So I'm going to go over obstacles next. Credentialing at hospitals. There's many hospitals in New Jersey that are not credentialing at all for pain medicine privileges at this time. My wife is actually a GI physician, currently changing her job into a private practice in New Jersey, and she's not getting credentialed at any of the hospitals right now. That being said, if you're willing to volunteer your time and help out to fight COVID, some of these hospitals are fast tracking the credentialing process. So something to consider if you have time, want to work in anesthesia or on the floors or on the units, and what hospitals you will have to be credentialed at in the next coming months, consider onboarding now, which may include virtual onboarding and fast track privileges. In terms of
Saurabh, I'm going to interrupt you. We have one raised hand for the question.
Sure.
So I'm going to go to the audience and take this question, okay?
Yep.
Yeah.
Sorry, I can't see the question. Did you?
Yeah. Dr. Dada, we cannot clearly hear your question.
I was not actually, I thought I sent it in the chat. There's a question for both the panelists. A couple of questions I have specifically, from Sean Lee's presentation. One of the interesting things that he brought about, it seems like he's doing in-office procedures. I would like him to clarify that. And the second question is also related to both Saurabh and Sean Lee. Saurabh, is with a group that has its own ambulatory facility, and I was wondering if you could give some input into how they're handling the ASC at present.
Sure, I can answer the ASC portion first. National Spine does not have any ownership in an ASC in New Jersey. Although as a physician that practices in New Jersey, as you know, under the Governor Murphy's executive direction order, most surgical centers, if not all, are closed to elective procedures right now. So essentially, we would be only doing emergent or urgent cases. We are currently following the society guidelines when it comes to urgent and emergent cases. My best example for you is if somebody had an infection of a device, somebody had a malfunction of a pump, in that case, to avoid additional emergent care, to avoid hospitalization, we may take on these cases. Other than that, our surgery centers are essentially shut down. In terms of in-office procedures, I mentioned that we may, on a case-by-case basis, do procedures. As I mentioned, I still have to fill my intrathecal baclofen and intrathecal pain pumps. That's something I consider an emergent, urgent thing. Other cases, doing certain procedures on terminal cancer patients. I did a brachial plexus block on someone who's got terminal cancer with involvement of the brachial plexus. I consider that an urgent case. The rest, I would say, would follow the current guidelines. So we're not doing as many as we used to, but every patient who is scheduled for a procedure is being counseled on the potential risks and benefits and the potential implications of injected steroids. So decreased volume.
Sorry, I mean, I didn't mean to interrupt you, Sean. Very nice explanation. But, my question was a little more far-reaching. I mean, it's not just a question of shutting the centers down. It's almost like you would have to actually be the physician certifying the necessity and also certifying that you have looked at the PPE and it's not going to be impacting the PPE thing. So it's a very onerous, it's a very onerous bar. Are you guys doing the certification when you're doing the procedures?
Sukhdev, unfortunately, I'll have to cut off here only because we are running out of time. And I have a lot of questions that actually have come online. So one of the questions is for Chris, and that is about the targeted training. if your fellows are not being trained that they expected, what is your response? And please be brief as much as you can. And then for the fellows who are coming for the next year, how would you be, convincing them that they will get what they are coming here for?
We went through the ACGME requirements for a pain medicine fellowship, and as of January, all our fellows had met the minimum requirement. And I must say, we all evolved our practices over decades of practice, and there's some underlying fundamental principles within interventional pain management that one can adhere to and still learn new technique. We teach our fellows good needle control, the consequences of what we're injecting, different mechanisms of injury. We teach them pain medicine, foundational principles that they can use to learn new techniques. So I'm not, especially with the current set of fellows we have and we've had the last couple of years, and it's been wonderful. They come out competent, technically competent, clinically competent, and they can learn new techniques. For new fellowships, we have a pain medicine fellowship. It's not just the interventional pain medicine fellowship. So we teach them pathophysiology, pharmacotherapy, opioid and non-opioid, and a range of procedures, common procedures, orofacial, craniofacial procedures, implantables, radiofrequency ablation. We don't teach everything, but we teach enough for them to be able to practice pain medicine just about anywhere in the country. And we teach them safety that they can build upon finishing and in the subsequent 12 to 24 months of subsequent to the graduation.
Great. The next question is for our lawyer, Adam. Adam, the question is, there is a hiring freeze and you already have the contract and now is hiring freeze. How would you reestablish the conversation?
Hiring freeze and the contract are two different things. I guess if you've already been given an offer, but the offer is not accepted, the employer can always revoke the offer. Right? If they say we have a hiring freeze, we're not hiring anyone. If there's a hiring freeze, but you were expected to start, and the question is whether or not you can continue to start and the contract's already in place, you can certainly have a conversation with the employer about whether or not there's some term under which you can renegotiate your contract. This is what's known as an unforeseen circumstance, right? There's an impossibility of whether or not the contract can be complied with. So, for example, practices where they have 0 patients coming in and there's no need, you don't have revenue, you don't have a need for someone to start working there. There is a basis for the practice to say, we can't comply with that contract. Certainly, it's good to try to work something out. Like I mentioned, to have an amendment to work on a new contract, but absent that, there's not going to be a lot of availability of what you can and can't do.
This is the last question for this panel. This is for Saurabh Dang. Now, you are the owner of the practice. You had already hired somebody, but now your practice has lost money and you are not in a position to continue their job. How would you, what kind of conversation you will have your potential employee?
Yeah, so I mean it's a hard thing to determine in terms of the future when we're going to be back rolling at 100% capacity. But we have multiple arms in our practice, so consider doing per diem work and anesthesia. We have an anesthesia group connected as well. So if they're willing to work on a per diem rate for a few months, then we would still try to honor that contract in the coming months when we're back to full speed.
That's a very, very good answer. At least some hopes there is no job. The last question is, actually this was the last question, but I'm going to take some time for Dr. Day. Dr. Day, do you have any trouble getting the fellows for next year, because now the residents are changing their mind and they don't want to go for pain fellowship? Dr. Day, can you hear me? Looks like he cannot. Chris, can you take?
Hey, can you hear me now?
Oh, yeah, perfect. Yeah.
Okay,
Did
sorry.
you hear my question?
Yes, sir, I did.
Yeah.
So fortunately, we have not had a decrease in the applicant pool. we have actually gone through and selected the ones that we want to interview. We're actually going to do our interviews through Zoom, kind of doing a panel discussion or a panel interview. So that'll allow us actually to, of course, interview more candidates, and no traveling is involved. The downside of it is we're not able to, show the facilities. We will allow the applicants to, if they want a one-on-one conversation with me as the program director, I will set that up. We will have them the availability of the current fellows to discuss the daily fellow life. So we have not set up the actual interviews, but I guess we will find out once we start setting those up in June, the drop-off of applicants based on the current situation. So that's the way things are going here in Lubbock at the moment.
Thank you, Dr. Day. And this concludes this first panel. Please stay as a standby. I will have some questions. If time permits, I'll come back to you. Thank you again, everybody, for your time. With that, we're going to move to our next panel. And we have a very excellent, outstanding speakers for next panel. And we're going to talk about the role of program directors and mentoring during this COVID-19, which is very high anxiety, uncertainty, and residents and fellows are really need some help and guidance. We have Dr. Deepan Patel as an expert who has finished his fellowship at NYU, and is one of the experts in a digital marketing and things like this. Dr. Patel is practicing in New Jersey in surgery center. He has done his fellowship under Dr. Karibo at NYU, and he's also a regular proctor for cadaver workshop at the New York, New Jersey pain Symposium. Here's Dr. Patel. Can you please take over?
Thank you, Dr. Dewan. Thankful to be here. Few brief comments on the role of mentorship during the COVID-19 pandemic. I just wanted to start by really advocating to the fellows the utilization of the society resources that are made available to you, especially during this pandemic and the difficult times you guys face. The attendance in itself can show that it's effective, and the fellows are really resonating well to the programs that we're conducting. So, the main thing itself is that what I wanted to really focus on is that really lean on your societies for the guidance and recommendations during difficult times. This one was really unanticipated. And, when you transition away from the academic world, this becomes really important. Staying connected, with your society allows you to obtain the guidance you need. And also the leadership that's put in place allows you to have a forum to connect with that'll allow you to decipher what information and guidance that'll actually really serve you relevance for your future practice management and navigating through a difficult time. So surround yourself with colleagues who understand this concept, and as you continue your career, in my eyes, you're really never too old or too young to benefit from a mentor. Myself, personally, having the benefit of working under Dr. Garibo, he was, the director of the department and also one of my mentors during fellowship. And, I had the benefit of serving as one of the directors for some of the other society mentorship programs, overseeing the operations and also participating in the mentorship programs themselves as a fellow. And you'll really find some real utilization for these once you leave fellowship. So in terms of the active role as a mentor that I serve, Dr. Dang and I both out of Garden State Pain Control, private practice, very busy. We have our own surgical center. We serve as regional private practice fellows, mentors for the New York and New Jersey pain fellows from the various institutions in a way to kind of let them connect with the other side outside of the academic setting that they typically spend most of their time in. So, we'll allow them to visit our practice with all the clearances and staying in contact over the phone. With the introduction of this pandemic, we actually transitioned, just like we did with our patients, to ensure that they had the opportunity to connect with us virtually using these virtual platforms, Zoom, FaceTime, whatever it may be, in terms of having any questions that may not have been able to be answered fully on these webinars. So, we typically discuss all the basics, the stresses of training, boards, job searches. The W-2 versus 1099 topic Dr. Dang mentioned earlier especially was one that brought up a lot of questions. So, a lot of conversations, they surround the usual bread and butter questions that fellows have. But, one of the things that, I've taken time to really emphasize is just simple check-in conversations with my mentees where, I just take the time to listen to them, manage their expectations about what to expect. A lot of their contracts that they had were production based, and they're really worried that they may not be making a lot of money. But, like Dr. Garibo said, you really just have to, put things in perspective. And that things will start to improve eventually. And then also just kind of suggest ways to contribute during their downtime, and remind them on keeping focus on what's important, and that includes their physical, emotional, and psychological health. So in terms of if fellows that are listening are interested in pairing with a mentor, there's a tremendous amount of opportunities within society and industry, including the support that Boston Scientific fellowship initiatives have given us. So, you can feel free to contact any of us, whether it's a moderator or panelist. We're all here for you. And regarding potential pairings, those programs are always ongoing. And I think you'll find them especially beneficial as you start to near the end of your fellowship, because the minute you end, the minute July 1 rolls around, it's a whole new fellowship and learning process that takes place. So I went through it myself, and I had mentors even within my own practice. My senior partners, Dr. Dang, Dr. Sinha, they've been crucial in terms of the development of my skills, and also the way that I interact with patients. So, don't forget that concept that you're never too young and you're never too old. So those are my closing thoughts, and I'll hand it off over to the group of program directors that are going to follow.
So thank you, Deepan. This was very helpful. You will stay as a standby for the question from the audience, and we're going to move to the new speaker, next speaker. Our next speaker is Dr. Daud Sayed. He is my former colleague from Cornell, and he's now the director of program director at the University of Kansas, and he's a fellow in interventional pain management, and he is the president of ESPN, and nationally, internationally renowned in interventional pain medicine, especially for neuromodulation and minimally invasive spinal and sacral procedures. Dr. Syed, please take over. Daud, can you hear me?
How's that? Is that better?
That's better. Can you hear me?
Yeah, I can hear you.
Yes, sir. Please take over. Yeah.
Thank you, Dr. Dewan. Thank you to New York, New Jersey SIP. Thank you to Boston Scientific for providing the resources for us to do this webinar. I'm looking at the attendee list, and it's really outstanding to see that we have over 100 people during the middle of the day for a regional fellows webinar. So that's really outstanding. So really what I wanted to focus my next couple of minutes on is what I think are going to, I don't want to scare the fellows, but really focus on what's going to happen to the training that fellows really need to get in advanced interventions. So again, we have all these wonderful tools. There's really been a technological boom in the therapies that interventional pain physicians can provide. We do things like interspinous spacers now, minimally invasive sacroiliac fusion. We're doing advanced neuromodulation with spinal cord stimulation. A lot of stuff that, to be honest, we were not doing even 2-3 years ago, let alone when I was a fellow under Dr. Dewan back in 2010 at Cornell. And when you think about, a normal fellowship year, our good friend, Dr. Neil Mehta out of Cornell did a survey on fellows on SCS, which I think we all consider more of an advanced procedure. And this was in 2017, and almost half of fellows thought the training was inadequate for things like SCS and advanced procedures. So this is going to be compounded this year, and we have it being compounded more by, there's this innovation boom as well. So I think this year's fellows, you are going to be affected by this training in advanced procedures, but all is not lost. I think, the big thing that we'll not be able to give you is that hands-on experience. Next slide, please. So what are the strategies for overcoming some of these training gaps in advanced interventions? I think, there's going to be a focus for considering increased cadaver labs and trainings at your local institutions and programs. So I think this is something to start to pick up the conversation with your program directors and faculties, especially if you're in a university settings, you have labs that you can potentially utilize to get some on-hands training. I think we're going to really lean on industry much more in these coming few months, especially for this year's class. I think industry partnerships and trainings are going to be critical. Pain societies will also hopefully step up and take the lead. I know that New York, New Jersey SIP is going to have a very robust training program for the fellows at their annual meeting. ASPN will be doing the same thing for this year's graduating fellows, as well as ASIP and others, I'm sure. Consider on-site peer-to-peer experiences post-fellowship. These can be just done through, reaching out to a colleague and saying, hey, can I spend a day with you at your practice and just kind of see SCS or minimally invasive SI fusion, or see how you put in a spacer. All those things I think are on the table. Also, you can also reach out to your industry colleagues to see if they can set up those things. I think those things are going to be more important than ever for this year's fellows. And again, just remember, no fellow ever comes out fully trained anyways. Really, the biggest things that you learn, the basic skills, how to take care of a patient, how to diagnose, all those things, you should have those even with 7 to 8 months of a truncated fellowship. Take advantage of this time to increase your knowledge base. So really, this time is really kind of rushed for fellows. They're kind of studying for their boards and trying to finish up their fellowship. And really, the time spent reading and increasing your knowledge base is usually sacrificed. So this year's fellows can really kind of hone in on that kind of stuff. You can really try to learn the basics. Those things will really serve you well as you get out in the next few months. What me and our fellows are doing, we're devoting this downtime to increasing our academic pursuits. So we have a weekly meeting now, and we're talking about studies that we can do, things we can publish, where we really didn't have the time to do that with previous years. And then again, I think Deepan hit it the nail right on the head. Seek out your mentors, and I've left my personal email address here for anyone that's on the call today to reach out to me for any questions or guidance. And then really just keep calm and don't freak out. It's going to be fine. This is going to be a few months. Just imagine that you're just going to have to extend your residency, your internship for a few more months. I think once we get out on the other side of this, things are going to be just fine. It's going to be an uncomfortable few months, but we're going to get out of it. Thank you very much.
This was wonderful, Daud. I have just one question for you. Your conversation with your fellows when they are finishing the training last year versus this year, how is going to change? What are you going to tell them?
That's a good question. I think, the messaging is slightly different. We're at least lucky enough that most of our fellows get very adept with the procedural training very early in the year. So for us, there's not going to be that, I need you to come back and get some more hands-on training. So a lot of it now is really trying to guide them on what to do over the next few months. Their jobs probably are going to look a little bit different than what they anticipated, guiding them on just some more common sense things. Don't make a big purchase. Don't go buy a luxury sports car or a new house right away. This is the time, we don't know what's going to happen over the next 6 months. So really be conservative, expect to not make any money, and expect the worst. And then if, positive things happen, then you'll be in a better situation.
Thank you very much. This was very, very helpful.
Thank you.
We are going to move to our next speaker of the panel. And next speaker is Dr. Lubinov. He's a very famous name, is key opinion leader in the country. He's a professor of anesthesiology at Rush University, director of section of pain medicine, and is a program director of the pain fellowship at Rush University Medical Center. Dr. Lubinov. Can you hear me, Dr. Lubinov?
Can you hear me now? I forgot to unmute. So I wanted to thank Sudhir for asking me, and thank you, Boston Scientific, for giving me the opportunity to share some thoughts with you. I think one of the roles of the program director here is to first maintain a sense of calm, as was mentioned previously, and just remind people that we have to get back to the basics. We still have to provide some ongoing medical care for these patients who have chronic pain, albeit that isn't by way of injection or other implant therapy for these past month or next month or so, but rather still just conservative care with oral medications, and particularly the ongoing prescription for opiate medicines. And so what we've had to do is had to all get up to speed rather quickly on how to conduct telemedicine. And so one of the things that we've had to do is to convert a practice that was always seeing patients in the office to a practice where we see almost no patients in the office, but rather do everything by either telephone or in the most recent week and a half, do this by some type of video medicine, either utilizing Skype or Zoom or some of the other video techniques that are embedded in your electronic medical record. And so it was early on that we saw some of the limits of our own individual way to handle this. And so our fellows were useful in to help us get this telemedicine up to speed rather quickly in the span of a week. And we've used it as a quality improvement project that they've all worked on in order to bring this into an active care where we can see 25 or 30 patients by way of video conferencing in essence. And in our particular place, we have a set way of how we manage patients with a medical assistant initiates a call, takes them down basic information about what medications are on, what needs to be refilled. The fellow then interacts with the patient to do the bulk of the interview and the documentation. And then the attending finishes off the conversation for the last several minutes and have this triad of people interacting with each patient. The nice thing about forcing us to get into telemedicine is that we've all learned how to use Zoom and these other video conferencing techniques. And so we can use Zoom to still do journal club. We can use Zoom to communicate with our fellows or with the fellows and the attendings. And so it allows us to do this online education individually by way of each individual fellowship. But also there is cropped up, this is just one example of what we're doing today, but all the other vendors are providing a number of different webinars that have been ongoing the past several weeks in order to bring us all up to speed on some of the challenges that we face. And then finally, I want to remind everybody that training and education is a lifelong pursuit. And you don't learn everything in your fellowship, just as was mentioned earlier. And so what we're going to do here is continue to learn as we move on to this next aspect of a fellow's practice. And so that may be through some of the techniques that Dawud had just mentioned, or it could be other techniques where you learn with somebody who's going to be in your new practice, a mentor that you're going to have to identify, let them walk through some of the things that you feel that you didn't get to do enough of in your fellowship training period. And with that, I'll turn it back to our next speaker.
Tim, thank you so much. This is really wonderful. I have one question for you. You have been mentor for so many physicians in this country, including me. Now, let me ask you how your mentorship has changed after in the last 3 months of or 6 weeks of COVID virus as compared to before that.
Well, the first thing I tell people is that this is now the 3rd crisis that has occurred in my 30 plus career, where it's dramatically altered the way in which we practice, in which fellows are being hired. Back in the 94, 95, 96 timeframe, we had a crisis where fellows were being trained, residents were coming out of training programs, not being able to find a job. The second time frame was in the 2007, 2008 Great Recession housing crisis. That had a dramatic impact. This is now the 3rd one. And so just make sure everybody understands that we will get through this. This is something that we've seen challenges before. My own gut tells me this might be a 2-year or 3-year process that we can finally look back and say, hey, I remember the bad COVID days. I'm not sure it's going to be behind us in just a couple of months. So that's the first thing I would reassure people with.
How do you see our new normal with your fellows?
Well, I think the new normal is going to be some element of trepidation, that they're going to feel less confident in some of the things that ordinarily fellows would walk out feeling very sure of themselves. And this is just all part of the learning process. And so I think that there's going to be a lot of telephone calls that program directors are going to be fielding July through December, asking, hey, you know, I wish I would have done more of this. Give me a quick review. And so I think we'll all be able to have that opportunity to carry on training for that next handful of months, even after they leave us.
Thank you very much. This was very helpful. Please stay standby. We will have some more questions, and we're gonna move to our next speaker. Our next speaker is Dr. Shalini Shah. She is the associate professor and vice chair of Department of Anesthesiology, and she is the director of pain program at UC Irvine. Dr. Shah is also our former colleague, trained at Cornell, and then she did a fellowship at Harvard. Dr. Shalini, please take over.
Sure. Thank you for having me, Dr. Dewan, and also to Boston Scientific. I want to focus on the current landscape for fellows, and more importantly, for all the fellows that I see at the list of attendees today, I remember most of you because you did interview with us. So you are part of our family. But this talk that I'm specifically going to give is going to be for you. So you know your rights as a fellow. What are my anticipations for my graduation requirements? What are my anticipations for my case logs? So this is going to be more informative for you going forward for the next 3 or 4 months. So we know that there's a drastic reduction in your procedural volume. I don't think anyone in the country is going to deny that, nor is the ACGME, okay? We know that most of your examinations or consultations are without examination. All right, so we understand there is also not only procedural decrease, but also the fact that you're not examining your patients and learning from that. And some of you, not all of you, but some of you, particularly those in the New York area, have been repurposed. So you're doing IVs, you're doing ER shifts, you're doing ICU shifts, and we realize that. So let's talk about what the ACGME's response to this is. Let's go to the next slide. So the ACGME has bucketed all programs into 3 stages. You could either be a stage 1 in which you're business as usual, and this is a funny term because I don't think anyone is operating business as usual. You could be in the stage 2 in which you have increased clinical demands, and then stage 3 where you are pandemic status. Just so you know, those of you who have, or those programs that have claimed pandemic status is only valid from 30 days from when you notify the ACGME. So it's not a permanent status for you, okay? And pandemic status really means that you can be repurposed. But for those that are in stage 2, this is the one I want to talk to you about specifically, because you have seen possibly a repurposing, or you may have been communicated to that you may have to be repurposed to other areas of the hospital. And you are not going to be doing as much pain as the fellows that are in the business as usual category. So let's talk a little bit about that. Let's go to the next slide. So the important thing is, this is what the ACGME states. Irrespective of which stage you're in, the ACGME mandates that you have appropriate infection protection, that you have adequate supervision for whatever it is you're doing, whether you're in the unit, whether you're doing anesthesia, whether you're doing pain, you still have to have appropriate supervision. And that if you do participate, if you have to be repurposed to do general anesthesia, if you're an anesthesiologist by primary specialty training, you can do no more than 20% in your primary specialty, okay? So that's good to know, that even if you have to work as an attending anesthesiologist, no more than 20% of your time will be dedicated to repurposing, okay? Next slide. So in that stage 2, or even stage 1, to be quite honest, and stage 3, there's 2 major themes that you as a fellow should know, or be asking your program director about. And I urge all of you fellows that are on this call today, make an appointment with your program director, okay? And what you want to ask them is, number 1, will I be graduating on time? And number 2, what about my case logs? What about my procedural cases, okay? So those 2 major themes are what you need to be talking to. And I want to give you some reassurance, because in terms of graduation, it is still up to your individual program director and your CCC to make that determination. This is not through the institution. This is not through the ACGME. This is still a local determination. And by the way, most of you have, whether you know it or not, or what the minimums are, if you have done 8 months of a fellowship, you have met your procedural volumes, okay, your case logs. But you still have graduation requirements. So you want to make sure you make an appointment with your program director and have that conversation, okay? That you're on track, that your CCC will recommend that you still go forward towards graduation. Let's go towards the next slide on, oh, okay, then we'll go back one slide to talk about your procedural logs. So know that the ACGME logs are a minimum. This is not to determine clinical competence, okay? Having 20 epidurals under your belt is not what the ACGME recommends for clinical competency. That's what they're just showing, that you need a breadth of knowledge. They're not showing that you need competency, okay, by having certain numbers of minimums or maximums. So knowing that, you should all feel pretty comfortable that you've met your numbers in terms of procedures, and just make sure that you now have a conversation about elective time, about research projects, your QA, QI projects, all those topics that you need to, that are also requirements, scholarly activity, that are all requirements. You need to sit down with your program directors and have that conversation. You know, it's a new time, like Dr. Day said in the first panel, we have to do Zoom visits for interviews. This is something that all new incoming applicants, for those of you who are applying to pain medicine, are seeing right now. Those of you who are applicants or thinking about being applicants, you probably didn't get the procedural or examination volume that you did, that other residents did during their residency rotation in pain, but it's okay, you're gonna learn it, okay? Just as Dr. Saeed said, keep calm and don't stress out, you'll be fine. So that's about it.
Thank you so much, Shalini. I have one question for all three of you, whoever wants to take it. The fellows are really stressed out, partly because they are finishing their training sooner than they expected. But one of the stress, and this is just anonymous, nobody's name is there. But their question is, they are deployed to ER and ICU and exposing themselves to a high risk situation. And this is what not they had signed up for. How would you handle this, not in a legal point of view, but as a program director?
Okay, if I can be frank, and you know, I have no problem being frank. There's a lot of things that will come to you in life that you didn't sign up for. And if you have that mindset, you're being very short-sighted. Because if you think that I'm only going to see this type of subset of patients, only do this in my career, you are being so narrow-minded, and you have such a vision of tunnel vision in some aspects. You know, think about this as a learning aspect. You're getting a knowledge base that you didn't sign up for, but yes, you're learning ICU care, you're learning ED care, things that you would not have otherwise. And you have your entire career to learn pain medicine. And life is long. You have a long life ahead of you. So if you think about it from that aspect, you're getting a couple months of ED, ICU exposure that you wouldn't have gotten otherwise. I wish I had that. You know, it can be a benefit. And just realize that you're going to have your entire life to do pain medicine.
So very well said. Tim?
Yeah, I would echo those same thoughts. And I guess just reassure them that if you take appropriate precautions, you know, you should be protected as best as one can from getting COVID. I've heard that some fellows or residents on the East Coast have had that infection. We've thankfully had just a very small handful across our institution. But as you said, don't be small-minded. This is all just part of life.
Yeah.
Yeah. Daud?
I don't really have anything to add. I think Shalini and Tim put it very, very well. I think these are just unprecedented times, so everyone has to be flexible. The world has completely changed in a matter of days to weeks, so just kind of do what's best for humanity right now.
This is an excellent message to the fellows and residents who are out there, and thank you for your time. And we're going to move to the next speaker. Now, this is very interesting. Dr. Lou Russo is not a program director. He's in a private practice, but he's been training fellows and residents for more than 2 decades in his private setup. He's the president of the Jupiter Medical Practice, and he's a keynote, rather key opinion leader in neuromodulation and minimally invasive the spinal procedures, and he teaches across the nation and internationally. So we are very honored to have him with us, Dr. Lou Russo.
Could I have my first slide, please? I don't think that's my slide. Anyway, my name is Louis Rasso, and I've been in practice for over 25 years in Jupiter, Florida. And a large part of my practice has also been on weekends, traveling to various either industry-sponsored events or cadaver courses and doing a lot of teaching. So I've had, like Dr. Dewan said, I've had a good amount of experience teaching fellows in the past. And, you know, I actually practice in a solo practice, and some people feel that's a dying breed, but it's worked well for me throughout the years, but it has its advantages and disadvantages. But it's been nice because I've been able to mentor physicians where they can actually come and spend 2 to 3 days with me and actually learn either some new procedures, sometimes just setting up an office. You know, the hardest thing, whether you even if you join a group and you're going to go join the group, but you're going to be the only pain physician, you're going to be responsible for really organizing that office. You don't want to have excessive staff and you don't want to be short staffed. So you really need to know what the essential staff is. Also, sometimes choosing an EMR is probably one of the most important decisions you can make. You know, I started practicing when we still had paper charts, and, you know, I love paper charts because everything was right there and it was so much easier. And, you know, I would just dictate, and then a transcriptionist would basically transcribe it and send it back to me. We put it on a patient's chart. So choosing an EMR at the time, even when EMRs first came out, I was one of the first ones in my area to adapt that. It was important in choosing the right one, because if you choose the wrong one, it actually can work against you. As far as what do we do today with the COVID crisis, I think virtual mentorship is going to be very important. Sometimes, you know, I've heard it said many times tonight that your teaching and your learning doesn't really stop at the fellowship. And a lot of times, you know, anybody who's in practice many years, we have new procedures, you know, interspinous spacers, you know, what type of person is going to be, you know, a good physician at that? How do we learn good, you know, surgical technique? We don't want to get an increased infection rate with spinal cord stimulation or other implantable device. Patient selection is huge. You want to have the right patient and with the right procedure, with the correct diagnosis, with a good outcome. And that's very important. And then obviously these days we may have to do a virtual tour of the office with actually designate what are the essential staff minimums that you need when you're starting out, whether it's with a group practice. You don't want to join a group and then all of a sudden they ask you to basically assemble a staff, and then you've overhired and they're going to tell you your overhead is too high. And sometimes the opposite isn't very good either. So in the past, you know, I've actually had peer-to-peers where they've come to visit. And then I actually started a program years ago called reverse peer-to-peer, where after somebody spent a couple days with me and they learned a new procedure or a new technique with me, sometimes I would fly to the location of their practice out of state and then watch them do a few of their procedures and help with their credentialing. Can I have the next slide, please? And then industry-sponsored educational events. I've taken part in, you know, a number of these. And one thing I could tell you is it's an excellent networking opportunity. You know, there was statistics years ago, and, you know, people can, you know, agree with me or not disagree with me, but almost 50% of people or new graduates, if they, within 3 to 5 years of graduate, they usually change jobs at least once. So that's a good place as far as an industry-sponsored educational event as possible new employment. But it's also a great networking opportunity, whether it's locally or nationally. What do these events do? They expose you to new technology, devices. You know, every industry has a certain take on why their device is better than the others, why, you know, what makes you choose one versus the other. And that's a big decision also when you go into practice. Do you want to use every device company or just limit yourself to one or two? There's a lot of, during these industry-sponsored events, there's a lot of open forum for discussion. There's no question that is a wrong question. We take all questions, and I can tell you, you know, having given many talks at these events, the more questions I have, I think it gives me feedback that I did a better job. All the companies now are offering even teaching during this crisis. And I've done a lot of that in the last few weeks, and I have even a number of them scheduled in the future. But as fellows, I would try to sign on for every one you can. So even if you're working at your fellowship all day, I think it's worth, just like tonight, getting on a computer with a Zoom type of device and listen to what you can learn and take as many notes, because we have to use this as an excellent opportunity. Even though we can look at it as a huge crisis, when people throw lemons at you, make lemonade. So I think we're going to try to find a way out of this. Our volume's down. I think the end is not as soon as people are anticipating, but I think we all need to stick together. And I can tell you, I will always be open to any fellow coming to my practice, spending a few days with me. They want to basically walk around, even with a FaceTime iPhone. I'd be glad to take them on a tour of the office, show them what we have, show them how the office works and how to organize an office. So thank you again, Dr. Dewan. Thank you, Boston Scientific. And I think this has been an excellent program. Thank you.
Thank you, Lou. This was very, very helpful. You've been very kind and offering fellows to come and learn from you. Let me ask you, as a private practitioner, how is the job situation for new fellows in private sector?
In my area,
yes.
I can tell you,
or nationally.
I think it really depends on whether they had already secured the position. But I think what I see with the volume decreasing, I think that employment, a lot of the employment will either be on hold or either a part-time or at a reduced salary. That's what I'm seeing.
Okay, so reduced salary is one of the options you have.
Yes.
Yeah. Thank you very much, panel. I think we have a lot of questions. I'm gonna ask some questions to the panel. One of the questions I have is again for the mentorship. Dr. Shalini, Dr. Dowd, I think team had to go, but the two of you, this fellow is not your fellow, it's some different program, but he wants you, either Shalini or you, to be a mentor. How would you do that?
Can I take this one?
Yes.
Yeah. The beauty of mentorship is that you don't need to be face-to-face, right? You can do a lot through email, a lot through phone call, a lot through even social media, even though some of us are not very big on social media, but it's all about creating a community. The beauty of mentorship is, for example, I trained under Dr. Dewan, that I can pick up the phone and say, Dr. Dewan, how would you handle this? I need to negotiate this. How would you do it? Whoever you think that you can find that would be the best advice for that, you pick up the phone and do it. I don't think anyone is going to turn you down.
Thank you. Dowd?
I agree 100%. I think it just starts with initiating contact. Most people that are involved in education, you can see, the breadth. There's people that are solo practitioners like Lou that are passionate about it, towards people like me and Shalini that work in academic medicine. Most of us are really interested in teaching, the future generations. So I think just start with contact, reach out. I think there's multiple avenues, whether it be direct contact, whether it be through society engagement, or through, industry.
This next question is for, thank you, Dowd. This next question is for Deepan. Deepan, how would you suggest or recommend to fellows and residents to reach out to different mentors digitally?
Yeah, I think one of the things that I've been really pushing is to use the digital platforms that they have available to them to start their own brand as physicians. And a lot of the networking that we've done amongst ourselves as society leaders and as well as young physicians is really adopt that concept. And it's really helped kind of expedite our career development. So the sooner that you get started utilizing these resources that are readily available on your phone, and that you always have with you, the sooner that you can connect with brilliant minds, not only here that serve us here in the United States, but all over the world where things are being done differently and at different speeds. So, that's the one thing that I would recommend and advocate for. We've all seen it help. And in terms of the adoption, we've seen it happen, I'd say exponentially because of the introduction of this pandemic.
Thank you so much, Deepan. The next question is for Adam. This is regarding the furloughs. can you, or would you let furlough the fellows and residents?
I'm still here. I'm sorry. Let me just
But
get
the
my.
question was, would you furlough fellows?
Would you furlough a fellow? Is that?
Yes.
Well, I don't. It depends on. I'm not sure the question. It's really a furlough is a situation that's up to the employer. If they have a need to keep that person on staff, anticipating that they're going to be useful in the future, that's the mechanism of furlough as opposed to a layoff. Is the question? Do you think the question anticipates that? Whether
the reason I ask you is maybe this may not be a question for you. Maybe it's for Chris Garibo and Shalini and Daud. This is for fellowship programs because they get some guidelines from SCGME and RRC. And I think one of the things that they cannot furlough the fellows. That was my understanding. Can you answer Chris or Daud or Shalini?
I mean, they've already met their minimum requirements, so it's not something that we even entertained.
Yeah, this ACGME has put out a statement recently saying furloughing is absolutely not permitted. So if you are a fellow and you're worried that you're going to lose your fellowship or you're going to lose your job, you know, your position is secured until your end of your contract, which is whether you started July 1st or August 1st. So you cannot be furloughed.
Do you agree, Daud?
I agree 100%. And if any fellows do get furloughed or let go by their program directors, I want them to personally find me so I can find those program directors that did it so we can hunt them down and expose them.
That's very kind of you. Thank you so much. I think we are running out of time. I don't have any questions. I would like to thank you all for your time and being on the panel. This is tough time that we are going through, and really thank you for your support. I also would like to thank Michelle and Sandra. They are really our support. Without their support, we cannot do any. There is a lot of work goes behind the screen that we don't know. And again, I would like to thank Boston Scientific. They always have stepped up in a situation like this. And when it comes to the fellows and residents, the Boston Scientific is always has taken the leadership. So my heartfelt thank you to the Boston Scientific, as the industry. You have always helped us, and without industry support, the educational activities would never survive. And lastly, I would like to tell our fellows and residents, keep safe. It's a tough time, but just keep in mind, we are all in this, and there is a lot of uncertainties. There is a lot of anxiety, and we don't know what's going to happen tomorrow. But just stay calm, and as Daud and Shalini said, this is our time to learn. This may be the opportunity to exploit our strengths and get out as a stronger and better person. We are there. We are, and I'm former program director, so I have hands-on experience, and all fellows or penalty are there for you. Reach out to us for any questions. The industry is always there for you. When it comes to fellows, I must tell you, all industry I have worked with, especially Boston Scientific, they are not there for their product promotion. They are there to support you and to help you. So reach out to them and stay connected in this time of social distancing. With that, this is the end of our webinar. I again thank you all the participants and have a very good evening. Thank you.
Thank you.
Thank you.
Thank you.
Have a good night.
Good night.